We'd start off by having excellent fellow Dr. Pericles Godolias present about sacral fracture classifications, because it always amazes me how many people don't know about sacral fractures. And we as spine surgeons should probably really be the main specialty to know about this, because this is the foundation of our spine. Before I go on, I don't want to embarrass them with colorful balloons or so. Dr. Godolias is the recent father of his second child, little Leonidas is my pronunciation. And so he has two young children, but he came here despite officially being on paternity leave. Dr. Godolias, on behalf of all of us, congratulations, mazel tov. Thank you for all your great work on research, and thanks for sharing this morning with us away from the family. So looking forward to your brief synopsis on sacral fracture classification, and then we'll go on with Dr. Yev Freibert on a case. And Dr. Mundis, whenever you're on, please let us know and we'll involve you in the discussion. Harry, take us onwards.
Thank you very much, Dr. Chapman, for the nice introduction and the gift. I will take a look later. So, my name is Pericles Godolias. I'm a research fellow here at SSF, coming from Germany, the University Clinic of Bochum, Beckmannsthal. I've been working there as a trauma and ortho surgeon for 8 years now. And I'm going to give you a brief history of the sacral fracture classification system, just to familiarize especially the audience that is aspiring spine surgeons and ortho and trauma surgeons with a couple of names that play a big role in the game. So first of all, we have this really big name in spine surgery. Every spine surgeon knows about him. It's Raymond Roy Camille. Basically, it's a French orthopedic surgeon who was born in Martinique and later worked in France in different hospitals and became a professor there as well. It's not only that we had sacral fracture case reports in the literature since the early 1950s, 1960s, but he was the first one who actually tried to put a classification system to it. A little excursus here, he's as well the one who gave us the technique for secure lateral mass screws, and as well, as far as I read about it, he came up with the idea of putting pedicle screws into patients, actually. He wrote a paper on that, and it was about basically the jumper's fracture, as he called it, because he had 13 cases and only 2 were car accidents, and all the others were suicidal jumpers. And he found out that there's different kinds of dislocation underneath the S1 vertebra, that he made a really brief classification out of it, and gave us these 4 types. This was in 1984 that he published this paper. And he went on, then Dennis and his colleagues in 1988, they tried to look at it from a different perspective, and they had a huger cohort. I think it was 776 pelvic injuries that they found these 236 sacral fractures. And they tried to classify them with these 3 zones. So as you can see, the first zone is a lateral mass fracture. The second zone includes the neuroforamina, and the third zone basically includes the spinal canal or the central canal. So this was in 1988. From there on, the development of the classification system developed pretty rapidly. As next name in the game is Herr Isler. It's a Swiss orthopedic surgeon who basically found out that when the fracture line extends to the S1, L5 S1 articular process, there's a chance that when it goes through it or medial from it, with disruption of the ligaments and the capsula with maybe only a subluxation of the joint, that you get a spinopelvic dissociation, which is basically a really severe injury and has to be treated differently than other sacral fractures. So he came up with this in 1990 in his paper. And then there was a discussion about trying to break down these classification systems into more relevant ones for the treatment methods. So in between 1901 and 2013, there were several huge surgeons, and I was lucky enough to work with some of them, like Mr. Duda, Hoffmann, and Schildhauer. Schildhauer was actually my boss in Germany, who wrote a couple of papers on the different types of sacral fractures. So there you can break it down to the H type, the U type, which is the second picture, the lambda type, which is comes from the Greek letter for L, and the T type fracture, which might be associated with a lumbopelvic or spinopelvic dissociation. Then the AO Foundation, of course, has a classification system by itself. Until 2018, they just classified sacral fractures basically in their pelvic ring instability or pelvic ring fracture system with instability of the posterior pelvic ring. But now, since 2018, they came up with their own classification system. You have these types, as we know it from AO classification systems, and then you can add a couple of modifiers to them for the neurological status. And they have different kinds like soft tissue damage and metabolic bone disease modifications. So this came up in 2018. This was basically my classification system history. Any comments?
Thank you. Why are we not better at using these classifications commonly in everyday practice? I mean, you're from a major trauma center in Germany, but is this a common knowledge in Germany? Whenever I look around our great centers, and we have fellows from all the great medical schools and residencies in North America, this is not taught. Why is that? And is this different in Germany?
Well, it's different. In this case, we're not really, when we look at CT scans with Professor Schildhauer in Germany, we are not taking the AO classification system into account, but we are looking at the U fracture, H fracture, lambda, and T. That's especially something that we are analyzing, and we're talking about spinopelvic dissociations there, of course.
Mm-hmm. So again, no real answer, but I hope that we can all get to the AO classification or see where its limits are and compare it to the other more classic ones. But whatever one uses, whether it's the Denise/Roy Camille, and I appreciate your shout out to the late Professor Roy Camille. We owe him a lot. I think it's always important to reflect on history. We should use something. We should understand that there are biomechanical inferences, and specifically when the lumbosacral facet joints are involved or what ligamentous structures are disrupted, it does matter. It is the foundation of our spine. So thanks for that brief overview, and look forward to your further research work. And I sent you a corrected paper last night.
Yeah, so thank you very much.
Good work. Next week, as promised, I have Dr. Yevgeny Freivert from UCLA. I'll ask him to introduce himself, and he has an interesting case. Greg, are you live yet? Not quite yet. Dr. Skuin, you'll have to impersonate Dr. Mundis until he's live and on. And Ben, please let me know when we have Dr. Mundis live. So he's going to give us our first case presentation, and Dr. Skuin and I will provide some discussion.
All right. Good morning, everyone. I'm Yev Freivert, one of the spine fellows here coming from UCLA. I'll present a quick case to start off the discussion. The patient in question is a 42-year-old female with right greater than left low back pain and intermittent left lower extremity pain at baseline. She presented to clinic with an exacerbation of her pre-existing pain and some new right lower extremity pain in kind of a not specific dermatome. Historically, the patient was diagnosed with scoliosis in 6th grade and was treated with a Milwaukee brace for 3 years, presumably to get her to the point of skeletal maturity. And at the point of her presentation, she'd been unable to work and maintain her normal activities just because her pain had become so exacerbated. She didn't report any bowel or bladder difficulties and any saddle anesthesia, and she reported some difficulty with gait, primarily secondary to her pain. On physical exam, she was full strength. Her reflexes were symmetric, and she did have a trace decrease in her left lower extremity sensation. Given these findings and given the imaging here, some routine measurements were taken demonstrating about 45 degrees of dextroscoliosis at L1 and 45 degrees of levoscoliosis at L4-5. She was also off balance. Her sagittal balance was a positive 6.7, and there was some degree of PI-LL mismatch as well. The patient operatively was an excellent candidate. She had no smoking history. Her bone health per DEXA was good. So she was taken for intervention. These are just some additional images demonstrating that she didn't have any significant central stenosis.
And quickly, if you hold up for a second.
Yes.
Rod, when you see a scoliosis patient, there's no egregious neurologic damage. How long do you get to know a patient before you make an indication for surgery? Because this is obviously a patient who's struggled with this since adolescence. And what tips you off towards doing surgery by, in absence of neurology, by just X-ray appearance?
I mean, I think surgery is the last resort. So, I mean, I think it's a good idea to get your physiatry colleagues. We actually have a very nice network up here at Swedish, both physiatry and non-operative, kind of a care team. Obviously she's young enough that I don't think bone density is an issue, but usually, the patients we're seeing are kind of postmenopausal or, and have low bone density. So I think all these things are important, but I mean, on a case like that, it'd be years before we operate on someone like that.
Absolutely. And for the sake of brevity, I actually skipped some history. Yeah. She'd been seeing physiatry for an extended period of time. She'd been getting injections, and kind of at the point of her presentation, she'd exhausted all other options for managing her pain.
So this is important. We want to get to know patients, and we want to make sure that they have had credible, real, meaningful, non-surgical care for a meaningful duration. And her, one thing that I didn't like was weight. She was a bit over. She's an administrator and has some physical activities with that, but that was a struggle for her. And this is one of those catch-22s, because of course we would like to see weight reduction effectively taking place, but she's very active. She's a relatively young mother of children. So that was kind of another factor, but the kids had all reached independent ages. So at UCLA, how long would you watch a scoliosis patient in your spine clinics?
I mean, it's variable. It really depends on, the acuity of their presentation, kind of their global clinical picture. I mean, certainly someone who is a less ideal candidate than this one would be monitored much more extensively. If at all possible, bone health would be optimized. All of the routine things that we would do. I don't know if I can give you a concrete time in terms of years or months.
I don't think we need time in terms of months or years, but there has to be a credible physician, preferably surgeon supervised, spine surgeon, be very specific, supervised area of time of observation. All right. So what are our thoughts in terms of management?
So, given her presentation and kind of the fact that she'd exhausted all other management options, she was taken for T9 to pelvis fusion with transverse process hooks proximally to create a little soft landing zone. She also underwent L1 to S1 T-lifts with a mixture of expandable and static cages. You can't appreciate all of them on this postoperative imaging because some of them are peak. And postoperatively, the patient did very well. She was discharged on post-op day 6, didn't need any kind of inpatient rehab. And at this point, she's well over a year postoperatively, doing incredibly well. In her most recent clinic note, she'd gone, camping and hiking without any difficulty. And she's also back to work. Kind of in the general theme of today's discussion, the real question here is whether there's any indication for SI fusion in a patient like this, in a patient with potentially a potentially less healthy general clinical picture. And then even though this patient did quite well, many of these long construct fusions do have residual superior iliac pain, and then is there a reliable method for differentiating that in terms of whether it's SI joint pain or myofascial or something else entirely?
Can you go back to the initial film? Dr. Hart just joined us. He's obviously well known in the deformity world and a member of the ISSG together with Dr. Mundis. So Ben, yeah, can you go? Yeah, this is the pre-op image, relatively young woman. We'd followed her with rehab for over a year. She'd been braced. You can see that as a young adolescent when this was first diagnosed, and she's miserable now. Short of a more effective weight loss, we've felt we've maximized everything. When you think about a surgical indication and a patient like this is pretty young, I think there's a little question. We have to go to the pelvis because of the nature of the curve. I think we can't spare caudal motion segments, which we usually will want to do in younger patients, I think. Do you fuse the SI joints? Can we stop at S1? One of the big questions in less invasive surgeries is, can we actually get good pelvic fixation? And is it enough to, in a osteodense patient, she has very good bone density scores. I forgot what they are, but assume they're normal or super normal. Is it enough to stop at S1? Enough questions? Do you have a microphone? Yeah, great.
Yeah, I apologize. I'm on call. I had a case I had to evaluate on the floor, so I'm a few minutes late to the conference. But that is one, I think, based on that curve, I would want to go to S1, and I do include pelvic fixation with these patients routinely. I do not do a formal sacroiliac joint fusion, and I don't think we really know the numbers of how many of these patients do end up with SI joint pain. I have been doing this long enough that I've had several of my own come back that are, 8-10 years or more out, and we've done a fusion at that point, a formal fusion. So I do think it's a long-term issue. I think we really don't know the numbers yet. But I think, again, if you go to this curve, to her films, there's just too much going on down at the bottom there to leave that unfused. In my opinion, I think that's not going to last if you try to stop at L5, say, or so I really don't see the benefit in trying to do that for her.
Dr. Skuin, he's well known as one of the pioneers of XLIFs. This was a collaboration with you. You're such a master of, and thank you, Bob, echoed my sentiments exactly, and that's not a coordinated response. You're a master of XLIFs. You've done these very early on. We did this together. You did the XLIFs first. What are your experiences now? Does this help us? Does this reduce invasiveness of this traditionally open performed surgery?
I mean, I think it helps, but I think, as Dr. Hart pointed out, I think the lumbosacral junction is a really important anchor point for doing the correction. And, with all the expandables and all the different approaches, I think, we can get more and more correction. Can you put up the AP real quick one more time? Yeah.
So which the post-op?
Post-op. But you can see, I mean, this is a great correction. Both coronal and sagittal balance have been pretty well restored. And I think, even when I look back 10 years ago, this would have been a 2-stage operation, maybe 3 stages.
Well, we did this in 2 stages.
Yeah.
You did the XLIFs first. How good have you become at predicting how many levels you can put these far lateral cages in?
Honestly, it all has to do with the plexus. That's usually the limiting factor. So usually after about 3 levels, you start to lose some of the signals.
Mm-hmm.
So,
and I'm going to pass the microphone to Dr. Godolias. We can't show you slides right now, but you're intensively studying the plexus and its intricacies. It's a prohibitive structure. Any insights in terms of safe intervals, and is a pre-sacral approach better, or a pre-psoas approach maybe better than a trans-psoas approach?
Thank you. So yeah, we have been studying on this, and so the pre-psoas approach is, of course, shows a little less transient hip flexor weakness because you're not going through the psoas muscle. We actually made a 3D print from 2 lumbosacral plexuses, and we found out that the L4, L5 level is mostly at risk for the femoral nerve, and L5, LS1 is of course mostly not reachable because of the iliac crest. It's not clear yet if which approach is actually the better one, I have to say, after all the studies that I've done on it. And there are certain complications with each approach, like the bowel injury for the prepsource approach, and of course the weakness and some nerve damage for the transpsoas approach. So there's not a real result yet that I can say that one is better than the other.
One last question to Dr. Hart, then we'll need to move on. Maybe we can have Dr. Robinson take the helm. Thank you, Yev, for this presentation. On the AP image, you saw a very robust posterolateral fusion. This is obviously one of the nice things of a traditional open approach. So we did a very extensive, thorough posterolateral fusion, and the x-rays at 1 year out show the maturation. You're a little bit more gray-haired also, like me. We were taught in the era before we had iliac screws to kind of turn down the iliac crest, the posterior crest, onto the posterolateral fusion bed. I've stopped doing that years ago, but isn't this a very good way to get a lumbopelvic fusion? And why aren't we doing that anymore? Is that truly so painful?
I don't think it probably has much long-term pain. And I only did that a few times. I'm trying to remember the name of the surgeon who sort of taught me that. And I saw it at a conference. And it was an incredibly robust posterior fusion down at lumbosacral junction. I think in the era of BMP, most of us have gone away from iliac crest harvest in general. But when you're putting pelvic screws in anyway, I do think taking more of the crest in order to use that bone in whatever fashion is probably not much of an impact, additional impact. I guess, if you're just going to use S2AI screws, I guess it would, because you do then have to expose the crest. But if you're using a traditional starting point, either as a second pelvic anchor or as your primary pelvic anchor, then you have access to it. And I think probably it makes sense to harvest crest in that setting.
So, thank you, Dr. Dekotowski, and good morning to you. Thanks for joining us. This was done by the Twin Cities Spine Center, and he credits Dr. Moe for the iliac crest turn down. Thank you, Mark. Great point. Dr. Robinson, fire away with your case.
All right, my name is Dr. Robinson, Jerry Robinson. I'm one of the Swedish spine fellows here, ortho trained in Akron, Ohio. Today's case, 72-year-old female with low back pain, just some back history, a very decompensated patient, very severely osteoporotic. Their DEXA scan T-score was -4.9, had uncontrolled diabetes initially, vitamin D deficient. They presented with 5 months of low back pain after a syncopal fall. The fall was 5 months ago. Initially diagnosed with a, quote, stable L1 compression fracture, but now feels like they're leaning forward. They used to be able to walk independently, but now require a walker for transfers and use a wheelchair outside the home. They have low back pain that radiates down bilateral buttocks into the thigh and stops around the knees. They endorse weakness in the bilateral ankles, have numbness and tingling throughout the legs bilaterally, and have a neurogenic bladder that's required a Foley already. They've been taking pain medications and wearing a brace without improvement. Here's just your physical exam after some small amount of optimization when the patient eventually reached us with an ODI of 86. You can see the weakness in the lower extremities and numbness and tingling. This was the initial injury from injury films. And then here's what we have now, 5 months post-injury with severe collapse. And you can see avascular necrosis of the vertebral body, as well as bursting and severe compression. Here you can see the two levels. Of note, there was a L4-5 spondylolisthesis that did have some movement with upright compared to recumbent films and the associated stenosis. And so here's some upright films when the patient was able to stand for these. And you can see their associated measurements. I apologize for not having flexion extensions, but it's mostly from recumbent to standing. But you can see some motion on those. And so just a pause for planning on that.
So great case. And I still don't see Dr. Mundis on here, so we'll have our internal discussion. So this is one of those almost everyday cases now where we have an elderly patient. She's mentally totally with it. She literally, under our watch for about half a year, has declined rather than inclined, despite multiple visits. If you can go back to that preoperative CT scan that you so nicely pointed out before. So this started relatively innocently and then collapsed pretty rapidly. Jerry, as you look at this in retrospect, was there something that tipped anybody off that this would turn into avascular necrosis? You recently gave a nice presentation on Camel's disease, which is the eponym for vertebral osteonecrosis. Was there something that tipped us off?
Overall, the patient was in relatively poor health. I can consider that a risk factor. And then also having some language barriers and other socioeconomic factors that led to, kind of being spotty with follow-up. I don't know that there was any radiographic findings or other findings of this initial presentation that would tip us off to eventual collapse and failure, because the patient did have a brace and was supposedly compliant with that. Whether or not you think that is meaningful, but by all standards, it seems like this should have went on to healing.
If you fast forward then to the CT scan after the collapse, so this obviously collapsed. This is classic Camel's with air in the vertebral body. At this point in time, is it too late to do a cement injection? Anything kyphoplasty, vertebroplasty?
I think that it would be higher risk. I'm sure there are some that would attempt it, but I don't see the utility in that, especially with the severe compression and the degree of debility. I think that it's more of a open surgical intervention at this point. The cat's out of the bag.
Yeah. We thought this would actually be dangerous. We have a wonderful interventionalist here with Dr. Glenn David, and we work side by side, elbow by elbow with him. And he reviewed this patient, the case, and he was not willing to put cement in there. He felt that the leakage risk was very high, mechanical support would be minimal. So that's why we kind of decided against that. But obviously the golden intervention time would have been the first couple of weeks when we had that first CT scan and braced instead of cementing. And I think there's a general trend in cementing severely osteoporotic patients far more aggressively nowadays. The work by Dr. Schonert, a colleague here in Western Washington, has actually been very pivotal in that regard, and his team. So, Rod, now we have a L1 burst fracture. We have a shaky L4-5 area. This is an extremely osteoporotic patient. She's immune compromised, surgery or not. And if you do that, how many levels above and below? Do we have to go to the pelvis or not?
I mean, I think you can make a case for, can you show the MRI again of L4-5? I mean, obviously, I don't know the patient as well as you guys, but the L1 seems to be a real problem. In fact, it looks like there's some conus or cord signal change.
Correct.
And that was clinically evident.
Yeah.
Whenever she'd sit up, she'd get severe immediate buttock.
So, I mean, I think you could just focus on that level. And I've done, a lot of cases where I go in posterior. Jens and I, we've done a lot where
I do think that there was some interval history where the patient had said over the past 3 to 5 years, they were having lower extremity weakness and back pain already in the lowers and mostly the ankles and feet. Yeah. So I don't know if that influences you one way or the other with that 4-5 as well.
Not really.
Okay.
So, I mean, I think you just have to, you can propose to the patient. We've done a lot where, you go posterior and get as much as you can out. And then I go lateral. I think that's a good case for that. Obviously you're going to have to deal with 4-5. I don't think, but I would probably think about just doing the symptomatic level first and then seeing how the patient does.
Bob, any other thoughts? Do we have to go to the pelvis again? Shaky 4-5 stenosis by itself, maybe not an immediate surgical indication. Can we somehow afford to stay on top of that, or given this really bad therapy refractory osteoporosis, do we have to just go long? And if so, how long?
Yeah, I mean, this is an unsolved problem, really, in my opinion. Osteoporotic burst fracture, we'll call it. I'm really torn. I have treated a number of them with just a laminectomy and a kyphoplasty of the affected level, or maybe the affected level and one above, one below. I actually have been pretty happy with the results from that. Her stenosis looks like it's almost too much to really kind of consider that. but I might try that approach in there and just see what you get. I just, adjacent segment problems in patients like these are just so prevalent. And I think I would wait on 4-5 at this point and really focus on the burst fracture, as Rod was saying.
We're joined by Dr. Glenn David. We just touted you about, you had seen this patient, and sadly, we missed our opportunity to do a kyphoplasty. If you go one back, please, Jerry.
This was the initial injury.
This is the initial one.
And 5 months
had she
later.
had a timely kyphoplasty, then this would have probably solved or prevented all the sequelae. But if you go forwards again, you saw her when I saw her, and this was at this point in time, and you said no to a kyphoplasty. If Rod can pass the microphone over to you, is there a chance to just try it? I mean, I hear sometimes this famous word, let's just try this. Does try it make sense?
Well, it looks like there's quite a bit of a combination occurring, and that's what kind of also concerned me, and a significant central canal stenosis occurring. Can you scroll through the axial there?
Oh, I just put a representative cut.
Just
Sorry about
pictures there.
that.
Yeah, that's what kind of concerned me as significantly, the combination, comminuted fracture occurring. It's kind of pieced up there. I think that, putting cement in would really kind of almost blow it apart, and that's significant central stenosis. So I wanted you guys' take on what you guys thought.
Yeah, we saw it together actually at the time, but we decided this was too comminuted, too much canal compromise, and there's not enough biomechanical substrate to keep any cement in place in the front of the column. So we thought this was a combination of neurologic compromise and mechanical insufficiency.
I do have a quick question for Dr. David. Do you have a threshold for amount of canal compromise, or does the posterior wall being compromised just caution you, or do you just approach them and say it's a little bit higher risk for cement extravasation, or you'll still attempt those?
At times, I try and go by AO classification as best I can.
Okay.
And look at, threshold is more the A3 type of fractures in comparison to not trying to stay away from more of the A4s.
Okay.
And send them over to.
Yeah, this by all looks at that looked like an A3 at the time of presentation, but this has fully collapsed and went on, unfortunately. So to move on from our plan, this patient went on to get T9 to pelvis with crosslinks, a local decompression at the kyphotic zone, and L1 corpectomy. The patient did receive cement augmentation and transverse process hooks, as well as cement augmentation at a few levels where some screws had to be realigned during the time of surgery. But here you can see representative cuts and seeing that our pelvic fixation is truly bicortical down the teardrop. And then here is the final result. I think we're about a month out from that.
And how did you do?
Sorry, I do have that. So patient does have normal sensation at this point in time, and 5 out of 5. The patient was severely deconditioned, so is working now on the front wheel walker as her main mode of transportation. So that is a great improvement in mobilization thus far. Fully still in.
Dr. Hart, you wrote as an oft-quoted paper of the many oft-quoted papers on rostral junctional fixation, and one of them was the cementing. I don't see you do that much anymore. I still do it sometimes, and I'm not a great friend of cement for a variety of reasons. But why did you stop doing that? The paper seemed to strongly favor it.
Well, thank you. At the time I did, and I think I learned that from John Kostwick actually back in the day. It was something that he talked about. So you did it exactly as and I still do sometimes do it, which is UIV and then UIV +1. I stopped doing it because I started using tethers, and I've talked a good bit about what I think is the importance of the posterior column in really clinically significant proximal junctional failures. So as long as the posterior column stays intact, even if we get a small compression fracture, a lot of those patients will do fine over time. And I think that there are some effects of the kyphoplasty or vertebroplasty I worry about the nutrition supply to the disc because the vasculature of the vertebral bodies are compromised, which is where the disc's nutrition comes from. And I also think that mechanically it may not be the best environment for the disc because you're creating a very hard, mechanically hard top and bottom above the disc. And so I felt I did see some fairly rapid degenerative change in the adjacent discs using that technique. And that's really those two reasons. Protecting the posterior column, I have felt I had a little better outcome. It's actually a little faster in my OR. And I think it's maybe a more biologic, better biologically in the long term.
And I use Tabitha, so I couldn't agree more. And over time, we'll just have to pool our data and see what works for whom. Rod, you've done a lot of MIS surgeries in the early years. It seems that you've come back towards open surgeries. I know, like, we have Mark Dekotowski and Dr. Rowe on the line also, who like MIS surgeries. I commonly hear in these more compromised patients, let's just do this MIS. You can't get a real fusion. She actually looks like she has a very robust fusion. We did use off-label bone morphogenic protein. What do you do, and why have you kind of gone away from percutaneous screws and rodding in these kind of cases?
I mean, I think whatever you feel comfortable doing. I think if in my experience doing MIS, I think going lateral is MIS. So I still consider that. I guess my only caveat would be I don't think doing screws percutaneously is any more MIS than putting them in traditionally. The reason I kind of converted back to open is because on a lot of these MIS cases that I was doing, I wouldn't get really good fusions. And so I think, decorticating the facet joints, all those things. And I think that technology's changed too. I think, the companies are making better screws. The between and biologics, I think BMP in some of these cases being used off-label has helped. But I think I wasn't getting as robust of a fusion. And also in a case like that, Jerry, go ahead and show the axial. This is a very difficult. A lot of times the bone is actually stuck to the dura. You have to disimpact. I mean, the whole goal here is to free up the neurologic elements. She's got, basically she's a spinal cord injury patient, incomplete spinal cord injury. So I think, this would be very difficult to do at MIS. I would say a handful of people could probably safely take that bone out posteriorly.
That's very insightful. Her dura was completely stuck down against that bone. Yeah. We had no dural tear, but we spent some time teasing that off. We obviously had neuromonitoring, and we did a nerve root sparing procedure. We did not have to cut the L1 roots. L1, is that accessible for far lateral surgeries? And what happens with the pleural cavity?
Yeah, I mean, I think it's a great area to do a lateral procedure because you're not having to worry about the diaphragm. I mean, not having to worry about the lumbar plexus. The main issue is the diaphragm. So, you're not having to worry about even, for example, some of the peritoneal contents like small bowel, large colon. So,
yeah. So traditional surgery, and so far she's done actually quite well. She's mobilized quite well. So thanks, Jerry. Any insights from your end? I mean, you're a young surgeon. Are you going to do this MIS when you come home? Or this is a very impaired patient. She had no wound healing problems or anything.
Right. And I really like what Dr. Esquian said, like from a percutaneous screw fixation in a patient that's diabetic, I'm not sure that you gain a whole lot of soft tissue sparing by doing 2 incisions along the spine compared to 1. And I feel like maybe you have double the chance with that. So I would favor an open approach for something like this.
Thank you. And we'll switch to Dr. Nathan Pratt, I guess, is next. Dr. Pratt is our administrative chief fellow. Thank you, Jerry, again. Well presented. And Dr. Pratt has a similar case with a different twist.
Yeah, a little bit different here, but very much.
Dr. Pratt is a neurosurgical graduate from the great University of Maryland and our many friends there. And we're very glad to have you here on the West Coast.
Thank you. How do I start the presentation? Oh, there it is. see at the bottom. Sorry about that. So thank you, sir. Nathan Pratt from University of Maryland. We'll look at SI joint fusion, or think about SI joint fusion in this setting of long segment fusions with pelvic fixation. A quick case study here, 80-year-old female, severe back pain, scoliosis. She's had a history of multiple decompressions, as well as a far lateral discectomy for weakness and numbness in the bilateral lower extremities, left side with the far lateral discectomy. This has been done over the course of like 5 to 6 years by another surgeon. She had the scoliosis present at that time as well. She comes to us after several years of worsening back pain. She'd had a spinal cord stimulator placed, provided minimal relief. She was becoming less and less ambulatory and was consistently having 9 out of 10 pain throughout the day. So she's unfortunately relatively unhealthy patient, as we've seen before. She's on chronic steroids for systemic lupus erythematosus. She's got a history of colon cancer that's now cured. She had prior spinal surgeries listed above. She's not necessarily obese, but she was just a very deconditioned patient with a chronic steroid myopathy, with osteoporosis related to her chronic steroid use. And on exam, she didn't necessarily have any focal motor weakness, though she complained about occasional foot drops and no focal sensory deficits. Preoperatively, her standing scoliosis film, she doesn't have a terribly positive sagittal balance, though she is, I don't have the measurements there, I apologize, probably about 5 centimeters, and then has a little bit of a coronal curve, but she's relatively balanced there as well. The problem is that she has multiple levels where she's unstable. She's got spondylolistheses at 4.5, 3.4, and retrolisthesis at 2.3. She's got severe canal compromise at every single level because of this, and has terrible bone quality. So there was a long discussion about what to do. The patient was becoming worse, deconditioned, weaker, and this had been going on over several years. And so the patient was then taken for a T10 to pelvic fusion. She had bilateral iliac screws, placed a traditional screw on the right side, and then sort of a modified trajectory there on the left. She did relatively well initially after the surgery, but you can see at 3 months, we didn't have a standing scoliofilm immediately after surgery. This is 3 months post-op. She developed proximal junctional kyphosis, perhaps not surprising in a patient with her level of disability. She came in with worsening back pain from her rehabilitation center, increasing problems with ambulation. Didn't really have spasticity at that time, but definitely required revision. She's taken back for an extension of her fusion. This is, unfortunately, we also don't have the standing scoli yet. She's actually in-house now for other medical issues. But 1 month after the extension of her fusion, you can see her construct looks much better. She's got a tether at the top through the rods and screws up there to try to prevent screw pullout. Overall, she feels, in terms of her spine, she feels much better. She's having some GI symptoms and things like that now. So the question then, she's got an adjacent segment problem. The SI joint is also an adjacent segment to the T10 to pelvic or T10 to S1 fusion. So does this improve outcomes if you fuse the SI joint? What are the data regarding sort of the biomechanics here? And there's not a lot of studies pointing directly to fusion of the SI joint in the setting of a long segment construct, but there are a lot of studies looking at whether or not you should go to the pelvis. So quick review here. This is actually a group from Maryland with Dr. Sansor looking at biomechanical fixation of SI joints in the setting of a lumbosacral or a lumbopelvic fusion. What happens if we stabilize the pelvis or if we don't? And what does that do to the SI joint? So this was a cadaveric study on 7 cadavers doing a T10 to S1 or T10 to pelvic fusion, comparing 6 different models. So they fused just to S1, they put in instrumentation down to unilateral pelvic screw, bilateral pelvic screws, unilateral pelvic screw with the percutaneous SI joint screws, no pelvic screw with unilateral SI joint screws, and then bilateral SI joint screws. So quickly, just to run through what they found. Movement at L5-S1 in an intact spine obviously is very high, but it was pretty much equal among the other groups except those that had an SI joint fusion. Now, these are not statistically significant, but there was a trend toward increased motion at L5-S1, even though they had spinal instrumentation across that level if the SI joint was fused, which just intuitively does make sense. That's inflection extension primarily, which intuitively makes sense. If you got a rigid segment down below, you may put more stress at the level above, even though that segment does also have instrumentation. Again, this is only on one cadaveric specimen, and it's not an in vivo study, but it certainly demonstrates that. And then range of motion, this is of the SI joint inflection extension. This is probably the most telling or most important thing to look at in terms of should we be fusing down to the pelvis for a long segment construct. You can see the PS is just a pedicle screw placement just down T10 to S1, did not include the SI joint or the pelvis. And you can see there's significant increased motion in the SI joint comparatively, not significant, but trend toward an increase in the motion in the SI joint compared to the other constructs used on both sides. And then looking at there was similar motion between the spaces with the, it doesn't show my cursor up there, sorry, with the bilateral SI joint fusions and the placement of just traditional iliac screws. So both those tended to immobilize the joint, although that's not necessarily the only point of placing iliac screws. It's also to reinforce the sacral fusion so you don't end up with insufficiency fractures and things like that. But just looking at SI joint motion, it is reduced. And then similarly, in terms of lateral bending as well as axial rotation, which is very limited in that joint anyway, you see a similar trend toward decreased motion if you put in bilateral iliac screws. So the primary take-home point that they illustrate is that bilateral iliac fixation was superior to or trended toward being superior to stopping at S1, which would then just increase your motion at the SI joint. Obviously, like we said, there's other reasons to go down to the pelvis, but at least in terms of the SI joint alone, this is at least some early evidence that is probably the right thing to do. Anyway.
So this is a big deal because a lot of the less invasive surgical techniques kind of technically have problems, and Dr. Michael Wong from Miami has kind of shown some options around that. They have a hard time kind of getting into the pelvic, true pelvic fixation, the pelvic ring, and they stop at S1. And we then in our clinic see these patients that initially look great, teetered off forwards and to the side because S1 is just given way.
Right.
So in your practice and what you've seen in Maryland, has pelvic fixation become kind of the norm for long fusions that go down to the bottom?
Absolutely. I would say anything that crosses the thoracolumbar junction, I can't think of very many cases, if any cases, where we didn't go down to the pelvis. And there have even been patients we had who had like an L2 to S1 fusion who ended up needing pelvic screws as well because they developed SI joint problems that were recalcitrant to sort of percutaneous fixation. I think we had a number of patients who had even short segment lumbosacral fusions who developed what was clearly an SI joint problem. I mean, you'd try injections and things like this. The pain would get better for a few days and then go back to how it was. And so some of the SI joint fusions were very effective, but we converted that in several cases to doing an open revision with placement of iliac screws and decortication of the iliac joint and packing B and P into it. And that was relatively effective in a lot of these patients. We didn't write up a case series on it there, but it's something that I think one of the spine fellows might be working on now.
So thanks for showing this. And obviously, this case also illustrates the frustrations of the failure points, which are nowadays mainly either at the top or the bottom. In your experience in Maryland, and I'll open that also up to Drs. Scourian and Hart, a lot of MIS surgeons say, well, you can just do percutaneous screws at the top, and by not disrupting the soft tissues, that kind of allows everything to heal better and avoids that. Is that your experience in Maryland?
I've never done that at Maryland. We did not do that procedure. So
You've seen that presented, right?
I've seen it presented before, but I don't think we saw a patient who had that. At least I don't recall it. Dr. Sanser may have had one, but.
Well, let's go with Dr. O and then Dr. Hart. So these rostral percutaneous screws, advantage or no significant gain?
You're talking about distal, like T10.
No, at the upper end, from T10 upwards to kind of just put percutaneous screws in there.
I mean, not really. I think, again, I don't know, Bob, I've kind of gone back and forth, but I think, when you have poor bone quality, this patient developed fractures within like 6 months above the fusion. So I think cementing is probably, I like cementing better than, tethers and all this other stuff. So I've kind of gone back to cementing the uninstrumented levels.
So Dr. Dekotowski has been very active this morning. Thank you for referencing our old papers about iliac screws. And again, he identifies that one can place iliac screws very nicely through percutaneous options. One sometimes has to use connectors and can't do the direct rod connection. I would add to the biomechanics paper of the wonderful Dr. Sanser that the use of these additional connectors does weaken the construct significantly. So all the gains from a great pelvic fixation, like what we had in that previous case with the bicortical screws, can be lost if you have these little connectors, because they are the new weak spot, then they're the pivot point.
Yeah, and we saw that at Maryland. I mean, we used traditional iliac screws for most of our cases, and they had offset connectors because of the way that they were set.
But now modified iliac screws. You don't have to do offset connectors anymore.
That we have, one of the other surgeons there did that. Dr. Crandall did mostly modified iliacs and would just be able to place the rod directly without the offset. So that was both those techniques I've seen.
So Dr. Dekotowski says, pass the rod through the SI screw, then bend the rod down, pull back all in line. By the way, good morning to Dr. Uday Gupta from India. He's a neurosurgical colleague there. It's always nice to have you online. Dr. Hart, any gain by rostrally putting percutaneous screws in? And maybe you can ask the fellows to switch to the last fellow whilst we're asking Dr. Hart. So multi-level fixation. Do we gain something by having percutaneous screws on the top? Is there less soft tissue disruption that then makes the surgery easier, less traumatic, less blood loss, less infection, less proximal? And that's probably the key question, proximal junction breakdown.
Yeah, it's not a technique I've tried. I know Cal Kabesh has been an advocate for that, and I'm honestly not 100% certain how he goes about doing that. I've always wondered how you are able to reduce the rod without really forcing it into the saddle of that screw if you're going to place it percutaneously. And I think what Mark Dekotowski is referring to is I start my constructs from the pelvis, not from the upper end. So I don't entirely understand the mechanism, but I'll say the steps that I've taken to reduce the rate of PJF in my own practice are first of all a posterior column tether, which goes from UIV to UIV +1 spinous process. I've also done that to the rib of UIV +1 and tied that down to the primary construct. I think it's critical that you really contour the rod at the top end into the upper two levels of screws so that there's zero pull-out force as you leave. And if we went back to that slide, I guess we may not be able to now, but I think the initial post-operative slide, the rods at the top there look a little straight to me and may have had a little bit of a pull-out force. And then the last piece is pharmacology. And if we have the opportunity to get these patients onto Forteo or some other anabolic agent for a good 6 months preoperatively and then maintain that postoperatively, I think that's a huge area where we can make impact as well. And I agree with cementation. There's a lot of surgeons who really still like cement at the upper construct. I wouldn't argue against that completely, but I don't use that as much as I used to for the reasons we spoke about earlier.
Last case presentation prior to our STEDS talk, and that's Dr. Jared Cook, and he has a, as of yet, unresolved case that will hopefully engender some discussions until Dr. Mundis comes on.
All right.
Jared, good morning.
In process. So I'm Jared Cook. I train in Las Cruces, New Mexico, and a sacral fracture case to show you guys. So this is a 55-year-old female, had a ground level fall onto her buttock, essentially what sounded like a syncopal episode, and she got up in the middle of the night. So she presented with severe sacral pain, left lower extremity paresthesia, didn't have any weakness or bowel or bladder dysfunction. She, was ambulatory at the time. It was just painful. Not a significant past medical or surgical history, and review of systems was negative except for HPI. Her physical exam just showed some left lower extremity, lateral leg, mild hyposthesia, but otherwise intact, and strength-wise, some left plantar flexion and dorsiflexion weakness, 4 out of 5, everything else intact. So the X-ray on the initial presentation, this is kind of the best shot. You don't see much on the X-ray, but you get the en face view of the sacrum, which is what you want to try to get. And generally, it won't usually tell you much. Sometimes it can, but this is what you expect. So we have a CT from that time of presentation, and so what we can see that that red circle, circle is around a fracture line, the left ala, and then you can see that there is a buckling of the S3, and then you can't see much, honestly, on the axial as far as fracture lines. And knowing what it kind of becomes later, you can squint real hard and see something, but at the time, not much. And here's the T1 slices at the time of presentation. Here are the stirs. So here's where things are lighting up. So mostly on that left side, you can see that S3. So left side, a little bit on the right, and so the patient presented presented for follow-up a few weeks later, and what you see at that point is there's definite cortical disruption at that point. This was not appreciable on the previous films, and then you can see over on the left side there's even some hinting at maybe a little bit of comminution in there, and we really see it well when we look at the MRI. So we have that that bilateral increased signal, and so essentially, I kind of wish that I had video, but you can follow this fracture line. It basically runs straight over and down. So basically, from classifications, to use the descriptive classification, it would be some variant of a U-type, technically H-type fracture. It's non-displaced, and the patient has not been able to ambulate comfortably. It's having a lot of difficulty with standing, but no weakness, no neurologic symptoms. It's all pain related. And so my next slide is the current plan. So maybe I should stop and see what the group thinks before going into that.
So again, classification-wise, give us the numbers, give us the names in the traditional French, and then the new AO wording.
Also, if we're looking at the Denis classification, because of that transverse component, you're automatically involving the canal. So you automatically are in 3. There's no displacement for Roy Camille, so that would be the lowest. And then in your descriptive classification, you're really at an H type. And then for AO, really doesn't have, doesn't have significant neurologic deficit, maybe some radicular, and no significant other injuries, comorbidities. And so I think with that aspect should still be a 0. Let's see.
Okay, so this is in the interest of time we need to move forward. So Denis 3, Roy Camille 1. This is slightly kyphotic, okay? But neurologically pretty much normal. Osteopenic patient. In the interest of time, I did a bad job with time management. I apologize. Bob, we have 4 main options. Wait and see, maybe a brace, although mechanically we can't do much unless we were to commit the patient to a lumbosacral orthosis with a hinged hip orthosis. Very cumbersome, very antiquated, probably nursing home placement. That's one option. Another option is sacroplasty. Sacral ala can be infiltrated with cement. Another option is percutaneous SI screws. And another option is lumbopelvic fixation. Why do you want to do what?
So, I wouldn't call it lumbopelvic fixation. I agree with the options you've listed. But the option that I prefer for someone like her is a formal SI joint fusion. And rather than do that with the current kind of limited access devices. I am proposing to do it by an open approach, and I'll put an S1 pedicle screw in and a traditional iliac wing screw in, and then formally burr out the SI joints and really pack them with graft. And that's really only about a 40-minute operation. We're not taking any motion other than the SI joints, so we're not really fusing any segments of the spine. And I've done that as my approach to SI joint fusion, which is for me an operation I do maybe once a year or once every 2 years. That's the way I approach it, and the way in her in particular with the fracture, I think it's a nice strong construct that's going to resist the plane of motion, which is really rotation in the sagittal plane.
Great. Very briefly, Glenn, any thoughts on sacroplasty in a case like this? Can we switch back to the CT scan? Rod, can you pass your microphone over?
Yeah. Just in the description of the fracture, I don't think sacroplasty would be a good idea in a case like this. I typically just do sacroplasty in patients where the fracture is mainly just in the sacral ala region. I think in this case, significant some level of hardware is going to be required to help stabilize the fracture.
Okay, pass it over. Rod, what would your vote be? Open surgery with formal SI fusions, lumbopelvic fixation, or as Bob described, kind of iliac crest fixation, percutaneous SI screws? What would you choose to do?
I think go back to is there a sagittal?
It's minimally displaced.
Yeah,
honestly,
I think you could potentially, I would consider maybe seeing her back and, getting a CT scan in 3 months.
It's so hard in these patients because this is the golden shot. Good. Greg, good morning. You're on. Good morning. So we've talked about you a lot. Thanks for joining us. I know you're totally busy down in San Diego. So briefly, before you start your talk and I introduce you, I don't know whether you saw that sacral fracture. We started the day with a brief sacral fracture classification, then went through several long constructs with the question of what should we do with side joints. Now we have a sacral fracture. I think it's Dr. Hart's case. What would you do in that patient? Neurologically intact, it's a Denise zone 3, Roy Camille 1, and an AOC3, but minimally displaced, no neurology. Is this something you treat surgically? I don't know whether you saw the images. Maybe we can go back to the images.
Yeah, I saw them. I actually would non-op it. I would follow it clinically and see how she does. I'd probably see her back on a monthly basis. If there's lack of inability to progress, then I think that's an indication to go. And I actually like Bob's approach to these where there's not instrumentation above it. I think if there's instrumentation above it, you have, in other words, if there's if you have a fracture through where the S1 screws go, for instance, I think that's an absolute indication to stabilize it. But in this setting where there's, there's not something there above it, that's a lever arm, I think you can try to go non-surgical. If you do surgery, then I actually also recommend what Bob said, which is I would put S1 screws in. I might change it just a hair, though. I probably use that SI device Bedrock along with an S2 alar iliac screw, and that way I get 2 points of fixation across the SI joint, and then that'll provide basic absolute stability across that section. It's super easy to hook up is the other thing. It's like instead of being, although 2 points of fixation from the iliac to the S1 is also easy to hook up. 2 points are always easy. When you add that third or fourth point, it gets a lot harder. So, but that's probably what I would end up doing if I had to do it.
Super comments. Yeah, I agree, but I'd probably do SI screws, percutaneous with washers, but I can't at all disagree with taking a wait and see approach. Alternatively, and I don't know this patient, I would probably send her to Dr. Glenn David for consideration for sacroplasty as he's identified. But yeah. One of those many unresolved issues in our case. Thank you, Jared.
Okay, I do want to bring up that the patient is 7 weeks out from this. They've been followed, tried to treat them non-operatively, and she's really feeling some progress at this point. So that's kind of why the surgical option was broached.
Thank you, Jared, for that.
Super reasonable. Super reasonable.
So, guten Morgen, Professor
Morgen. Los geht's. Hey, Bob.
Warning to all, this will be a lecture in Alpine German. So Professor from San Diego needs no introduction, but we'll introduce him nonetheless. He is a well-respected authority in deformity surgery. He's a co-director of the San Diego Spine Fellowship. He has also advanced the cause of minimally invasive surgery, and his talk today will be about MIS and deformity surgery. Where are we? And we're really looking forward to your provocative, thought-invoking, and heavily debatable talk. Thank you, Greg.
Awesome. So I actually got to cheat, and I listened on a little bit early as well. I throw this up here. You guys can see this okay?
On our screen, not yet, but let's see on the public screen. Yes, we are live. Ben, can you switch?
Awesome.
Yes. Perfect. There we are.
Cool.
Clinic. Here we go.
Stead Talk. I love it. First of all, thanks so much for having me. Like, this is so cool. You guys have, through this whole shifting in COVID, been a very beautiful educational presence in spine surgery, and I commend you for all the effort you had to put into it. Certainly looks like it's paying off. And anyways, thanks for having me. And I'm so blessed to be with you guys this morning. So here's my disclosures. None that really relate to it. There'll be some peripheral things around it. I did kind of hop on the call a little bit earlier, the conference, and I saw this question come up about percutaneous pedicle screws. So I quickly threw in some slides because this is something that's plagued us for a while to understand the impact of percutaneous fixation at the top of a construct. So I'm going to pivot for like 2 minutes and just share this little paper that we wrote with that. So there's a bunch of different strategies we can use, as we know, for trying to prevent PJK. We ended up looking at a group of patients that had either open or MIS surgery through the ISSG. And then we did some propensity matching so that we sort of had two equal groups. We used age, BMI, their pre-op and post-operative alignment goals to see where they ended up. So we called PJK in two groups. One was mild, the other severe, and one would be 10-degree change from pre-op, the other 20-degree. We had 1,000 patients that met criteria. We put there were like 114 in the MIS group, 909 in the open. The MIS were slightly older with higher BMI, but no real difference in alignment between the two groups. Open had more levels fused, bigger change in their PILL, and a bigger change in their lordosis, as you might imagine. But once we matched them, we had 77 in each group, and then at that point we had no difference in demographic data. At 1 year, we saw a little bit of a difference in the NRS back pain scores, which were a little bit lower than the open. But the alignment really was no difference between the two groups. And this is actually an important piece because we always talk about alignment as a particular causative factor in developing PJK. So at 6 weeks, we had PJK in about 20% in both the open and in the MIS group. And at 1 year, slightly larger in the open group versus the MIS, but that did not reach significance, and that could be a little bit of underpowering as we look at it. The PJK that was the larger group was 2.6 in the open and 3.9 in the MIS. And so the PJK angle really was not much difference between the two groups. It was 4.3 versus 4.2. So again, not a huge difference. The MIS group had more interbodies, but there was no difference in the rate of revision surgery between the two groups, and major complications occurred a little bit more frequently in the open group, as we've shown on numerous different occasions. And so while we intuitively thought that percutaneous fixation at the very top of a long thoracolumbar construct would be protective, we did not find it necessarily protective of actually developing PJK. So, so just to throw that out there, I don't think we saw the answer yet, but I think maybe metal is not the answer. Maybe there are other things that we should be focusing on. So anyways, now to the STED talk. We're going to talk a little bit more about like MIS deformity correction, where we're at today. So a couple principles I'd like to talk about before the talk. And by the way, if anyone wants to interrupt me, I'm totally happy to stop talking and do questions or engage in a discussion and however you guys want. So please feel free to do so. I always say the implant does not have an IQ, the surgeon does. And so where we like to blame technology for things gone wrong. A lot of times it's the hands that are using the technology that are the problem, not necessarily the implant itself. And in general, that's how I try to approach every case, where it's me making the decisions. It's not really the implant that's the issue. There's some generalized inner body data out there that has inherent flaws. And this is where the inherent flaw comes in. Not all patients are created equal, and not all surgeons are created equal. And because of that, when you see aggregate data reporting on different, abilities to achieve whatever kind of lordosis or coronal plane correction, you have to always understand it goes back to the surgeon, what they're trying to achieve, and did they achieve the alignment goals that they set out to achieve. And if they didn't, we have to be careful not to blame the technique for that either. With patients, flexibility is key. The inner body technique does matter, and how you position your patient when you go posterior. So when you position them for posterior surgery, that matters as well. And with surgeons, like, our experience matters. It's just the way it is, right? When you're a year out from your fellowship, it's very different than when you're 20 or 30 years out. And that experience plays a huge role in what you're able to do in the operating room. So understanding your postoperative alignment goals is also critical, because how do you know what you need to achieve if you haven't thought about it ahead of time? All right, so planning is critical. I'm sure you guys talk about this all the time, but I'm going to keep punching this dead horse right now, because it is that important. You need to measure your key parameters. You have to quantify the need of your realignment. That includes both the sagittal and the coronal plane. And then you need to evaluate your options, the fixation options, your osteotomies, which biologics you're going to use. And then I like to go execute that plan. Patients always say, like, hey, while you're in there, if you need to do whatever, you have free will to do that. And by the way, can you look at that other disc to make sure it's okay? Like, I don't like surgery like that. That's not my style. Like, I feel a little bit more like I've done a ton of planning, and then I'm gonna go execute this mission like a Navy SEAL would, or something like that. So that's kind of how I approach these surgeries, where yes, you can pivot left or right, but you've really thought about it as you go through it. So when you think about deformity correction in the MIS setting, there's a couple of things that you always want to kind of have your head wrapped around. One is, with MIS surgery, you're really using the disc space as your workhorse. Like, stuff is happening through the disc space that you're going to get your correction through. Flexibility does matter. So if you have someone that has a rigidly fixed curve, well, then MIS techniques may not be the best for that. If they've had previous fusions, or if they have tons of bridging osteophytes, things like that, you may want to reconsider your options in that scenario. Again, fusion is the one thing we're trying to achieve. And so understanding where you need to get the fusion, I think, is very important. And then anterior column is your correction, and your posterior column is your stabilization. Even for these MIS cases, we do work through a multidisciplinary conference. And just to say that just because it's done MIS doesn't mean that they get to skip what other deformity patients have to go through. So we do have I wouldn't call it rigorous, but we have a process in place that helps us identify patients that are at risk. And if we need to, we can modify those risk factors. So we're going to go through some of these principles real quick, just kind of so you get in my brain a bit on how we do that, and then we'll look at some cases. But the anterior column, again, is your workhorse, right? You use the disc space, you get the sagittal and coronal alignment that you need, and then this is also where the fusion happens. And so a lot of times with percutaneous fixation, I hear a lot of surgeons talking about how they fuse posteriorly MIS. I'm plus or minus on that. I think sometimes you can see some good data from that, but in general, I would say the anterior column really is where you're going to have the biggest and best impact on your ability to fuse. And again, measuring your alignment is important. So when you think about the disc spaces, this is something that Uribe loves talking about, is like seeing that air in the disc space. Like, that's just an invitation to help make things better. And so I love air in the disc space. It's a very good sign. Have they had previous surgery? Like, this patient's had a previous fusion. Having a CT scan to evaluate, that's really important. You also want to check posteriorly, though, if they have ankylosis. Like, some patients will have fused facet joints posteriorly, which means that your ability to do correction through a really large overgrown facet may be limited, and on occasion may require you to release that facet before you go anterior. Although I try to avoid that, because that just adds a lot of time, and I don't like adding a lot of time. But again, these pockets of air, that's a great sign, because that means we're probably going to be able to get some good correction through that. Flexibility is really important. You want to evaluate both regional and global flexibility. Intraoperatively, I always assess flexibility. And then also realize like every patient's a little bit different. And just because it wasn't flexible at one point in the case, you have to keep reevaluating that throughout the case, because as you loosen things up and make them more flexible, their alignment will change. And you may think that you need to get a lot more correction, even especially in the sagittal plane, when you realize you may have accomplished your goal like an hour ago. In the office, I assess flexibility really with standing versus supine imaging. And mind you, I rotated the image on the right to make it look like it's standing, but this is him laying down. And you can see that there's flexibility that's inherent to that space. And so understanding that flexibility will do a couple things. One is it'll tell you if you can work through the disc space. And then secondarily, it'll also help you plan, like, do I need to do a little bit more? Like this guy, for instance, has some of these like kissing spinous processes posteriorly. So you're going to have to really elevate the anterior column in order to make that work, or release it posteriorly. So some things you just have to pay attention to, because they'll block you from what you can do. It's also true in the supine position, just understanding what happens when they lay down. And then this is what happens in the operating room. So I'll position my patients in the OR and say, okay, where am I at relative to what I need to achieve? Having an image like this before you get going, and you can do it with a spot lateral, honestly, with either a cassette or with a fluoro, just to take a look at your lordosis, which is the main thing that we can alter in the operating room. So I'll just challenge you guys to always take a look at these laterals, just to make sure that you've done what you think you need to do. So here, this patient, for instance, we're able to see on the operating room table with position, you can see the chest rolls up high, and then the pelvic rolls are down well below her femoral heads, which allows her to rotate into it. This is where she was pre-op, and so you can see her TPA significantly larger pre-op than it is positioning in the operating room. When it comes to fusion, like we said, the anterior column is the workhorse, and I see if we can get this video to play here. Sorry, my cursor's. I guess hitting the button 10 times isn't good. It's like the impatient doctor, right? Yeah. You hit it over and over again. Let's see if we can get it to go here in a second. But the bottom line is, just to show this here, having the interbodies in place, especially some of the more modern interbodies that we're using now that have biologic surfaces, I think are awesome, because I think they're showing us that A, we're getting a lot more stability when we place these implants, and B, we're actually having some on growth and perhaps even through growth through the interbodies in a more meaningful way than if you just have a central aperture. We've also gone away from just blocks of metal and now gone towards these more biologic implants again that have better matching modulus to the native bone of the patient and allow for some of that through growth. So the anterior part is our correction workhorse, and the reason this is important is you have to understand what you can achieve at each level to make sure that you can achieve your alignment goals. So with this patient, for instance, she has a 62-degree PI. We're going to try to get her a little bit better. She's currently with a lordosis of 28, so we're shy of about 30 degrees. Her L4 to S1 is 18 degrees, and really our target goal there is 40 to 45. Her pelvic tilt's not bad. Her TPA is pretty high. Her SVA is pretty high, and her global alignment's high. So we know we have some work to do in this patient to get her back into alignment. So one thing to do here is the plan is to go through this whole planning process. So she had an A-lift done at the bottom that has a hyperlordotic component to it. Then we did the laterals above. And what you're able to see then is a very nice balanced correction throughout her lumbar spine. This is sort of a tweener CT scan where you're now able to evaluate where we are. The middle picture here is the pre-op CT, and then the one on the right is the post-op CT. And you can see now we have a very nice harmonious restoration of her lordosis. We've hopefully made the apex of this curve in the right spot around L3-4. Hopefully, again, changed her pelvic alignment to something that is more conducive for her overall alignment. So you do have to kind of figure out also which levels to be included in your arthrodesis. Basically in the lumbar spine, if I'm doing it minimally invasive, I feel like I need to have an inner body there. So if I'm going to try to do it MIS, I'm going to try to have an inner body at the part where I'm going to do a percutaneous screw. You have to figure out like what the must levels are. So you want to draw a plumb line. You want balance corrections, which means you need to understand where your cob angle is. You don't want to stop this at the apex, for instance. You don't want to leave a potentially unstable disc unfused. So if you see a disc that's moving around with your imaging modalities, whether it's from a standing X-ray to MRI, if you see shifting there, you just want to make sure that you don't leave anything unstable unfused, because they'll fail. And then you need to apply both the degenerative and deformity principles when you're determining your UIB and LIB. So again, I don't like stopping fusions where there's a significant curvature, or especially in the sagittal plane, if the screws aren't going to end up being close to parallel to the ground. So how do you get your coronal correction? It's usually through multi-level laterals. I actually use smaller cages, not bigger cages. I believe having cages that are downsized a little bit. So instead of overstuffing the inner body, I try to keep them. Obviously, I need the tension to be right so that cages don't move. But I do feel like you're able to manipulate the spine a little bit better if you don't have huge cages in there. And then the one really important piece here is the fractional curve, and you have to pay special attention to the fractional curve and how to fix that. And to that point, if the fellows in the room have not read this article, I strongly encourage you to take a look at it, study it, read it. I think it's a really good article. It's very simple. It takes you through 3 different classifications for coronal imbalance. And I felt that this has actually been one of those papers that has changed how I practice deformity surgery. So just strongly recommend you guys take a screenshot of this or whatever and read it. It does not take long. I can text you guys the PDF too if you just want to email me. In the sagittal plane, when you get the correction anteriorly, you have to understand what you need to get there as well. And so, it used to be like, and I'll show some data in here in a minute, where historically we were not good at achieving sagittal plane correction. I will tell you that is for sure not the problem anymore. If anything, we've overdone this one too many times and achieved a little bit too much sagittal plane correction. So how do we get that? So these things called an ALIF ACR would be, we just published a study on this as well, where you're basically doing larger corrections through at the base of the spine, L5S1 and L4L5 in particular. And that's where you do a really wide release of the disc space, crack open that space, and then place a hyperlordotic implant. You can do multi-level lateral interbodies. You can go as far as a MIS PSO posteriorly, and then certainly from the lateral plane, you can use anterior column realignment tools to cut the ALL and get your sagittal plane correction there. So back to this case that we're sort of showing, really flattened end plates down here. They're parallel basically. You do the ACR down here at 5.1. You can see that we put a 30-degree implant in and got 20 out of it at that point. I'll show the final product of that case here in a minute. Here's another case where the point here is to stabilize the spine in the coronal plane, because she really was not off very much coronally, and in the sagittal plane, just tweak that a bit to get her back into a more normal alignment. It's a type A curve, and so this patient did not need a large fractional curve correction. It was mainly just stabilizing that the intervening levels there. And to your point, guys, earlier, these top 6 screws were all placed percutaneous with a little facet fusion there. And again, I don't know if that actually fuses. This gal is now 3 years out, and these screws have not wiggled free. I don't know the answer to this question. I think there's a time and a place for it, probably. But when you go in there with a little burr and you put some bone graft in, I'm like, really? Does that really cause a fusion? I don't know, but I certainly am a little bit skeptical of it. But anyways, multi-level laterals to get your coronal plane deformity correction, using the interbodies as well, and patient positioning to get the sagittal plane better and to get a nice result there. Here's this concept of an ACR, 4 degrees of kyphosis throughout the section. Put a big old implant in the front, and you can really get really substantial deformity correction through a single level. You have to be careful with this, because you have to understand your Russelli pelvis types, because where you place this inner body matters. If you put the apex of this deformity, put the apex of this lordosis in the wrong spot, you're going to set yourself up for PJK. So this patient needed it at L3-4 disc, so it worked out okay. Here's another way to get saddle plane correction. This patient ended up having a pseudoarthrosis through a T-lift at the mid-lumbar spine at L3-4. In this case, we went in from lateral and took the T-lift out, put an ACR in there, and then flipped them posteriorly. Opened up the bottom section, did a PSO through the bottom, and then used percutaneous implants the rest of the way up. So we're able to get those implants out and reconnected through stab incisions instead of opening up the whole thing. So to principle number 5, screws to the rebar. So it's really our obligation to provide the best environment for bony fusion. A lot of people still talk about standalone implants. I'm not a huge fan of that. It doesn't make much scientific sense. I think the fusion concept makes good sense, but the stability piece really is where we get it with the screws. I don't know if everyone needs 4 screws per level. I certainly am someone that a lot of my degen cases have gone to unilateral fixation with a large inner body up front. I think with T-lift, I do like bilateral fixation in those scenarios because you are disrupting the joint enough to cause some instability there. So. As I said, don't get too caught up in the type of procedure. You need to make sure that your patients are going to fuse. So even if that means abandoning the MIS thing and going open to get a fusion, do what you need to do to get your patients to be fused in the best way possible. It's a disaster if you leave a bunch of people with non-unions. So therefore, I believe it's best to have an inner body in the lumbar spine when you're using an MIS posterior technique. So that's where I usually stand my ground, like the big inner body up front and then the screws in the back. I think it provides a really nice, stable environment. It's definitely great from a load sharing perspective, and there's a large surface area for fusion. So just to show you, if you guys aren't using, this is just using SurgiMap. It's free software. This is basically a 30-second video showing you how fast it is to actually measure patients on this platform. People always say, how do you have time to do this in clinic? A lot of times I do it after clinic. Sometimes I do it before. Honestly, a lot of my fellows use it ahead of time. But you'll see that just even drawing out the entire spine is as simple as basically 6 steps, and then it literally plugs out all your numbers. And then you can add different parameters if you want. This is adding a thoracic pelvic angle, for instance, just so I can have that for my own reference. But all that takes about 30 seconds. So it doesn't take very long for you to understand where your patients are at and for you to make a surgical plan from that. So, always have to ask yourself what the right question is. What do we need? Do we need global alignment? Do we need regional alignment, or just segmental alignment? And then, what are your goals as a surgeon as you're trying to achieve all that? So this is just looking backwards by, gosh, like 8 years now. But what I wanted to show here, this is from the ISSG database. The MIS group had the least effect on lordosis. The hybrid had the highest. And the hybrid, it makes sense because you have these lateral inner bodies, and then you're opening up in the back. So it's like the best of both worlds with regards to achieving correction. But you can see in the MIS world, you're fusing 3 or 4 inner body levels and really not achieving much in the sense of lordosis. And this is the PILL, again, quite ineffective from an MIS standpoint versus hybrid being very effective. You can get all kinds of different studies that look at the ability to achieve or not achieve lordosis. I do like showing this because just putting the cage in really doesn't translate into you getting your alignment goals. This is one of Uribe's early papers, and he uses this a lot to say, listen, you got to pay attention to what you need to achieve, because just putting a plug into a disc space does not mean that this is going to go well. Also, where you place the cage matters. And if you tend to put it more anterior, then that is good in the sense that if you're trying to achieve more lordosis, I think anterior cage placement can be beneficial. So then looking forward a little bit, this is still looking back about 6 years now. What we found here in patients with a low PI, so patients with a mild deformity, the MIS really did remarkably well, extremely well, if I would say it that way. In the mid PI range, we still did very well. Patients got a lot better. We didn't necessarily overcorrect them. We didn't necessarily correct them that much, but that may be why they did well, is because we're not overdoing the operation. But man, in this high PI group, we were creating fixed flatbacks, and so this group actually did quite poorly. Their ODIs didn't change much. They still maintained a severe disability in their ODI. So this is the group that we've had the most struggle with. We know as we're like dissecting ourselves in this, is like, is it our ignorance? Is there a planning error? Is it the implant problem? Is it limitations of our technique or our training? And we kind of realized that we're sort of maybe asking ourselves the wrong question. Like, instead of saying how much is a lateral, for instance, affected, maybe we need to do things a little bit differently. And that's where we came up with these anterior column realignment tools, or the MIS PSOs. So a lot of different data that's out there now that looks at better ways to get improved alignment. And so we started this MIS study that's prospective versus the last version of which was retrospective. And in this prospective group, we were able to look at patients in a very similar way to see kind of where we're at now. And you can see that our ability to achieve a postoperative correction within the appropriate alignment goals is getting a lot better. We have a 7-degree change in lordosis in this group as an entirety, but realized we got them back into alignment. So we didn't need much more than 7 degrees. So did we achieve what was needed? Absolutely. If we look at those with more of a sagittal plane disorder, so we look at those with a plus modifier. If you look at the Schwab classification for deformity, so these are patients that have a higher SVA, higher PILL mismatch, and a higher pelvic tilt as their threshold for looking at them. You can see that even in this group, our ability to achieve patients back to where our alignment goals is now a lot better. And so thankfully, we've been looks like we're actually making some of these changes. So we had a 14-degree shift, which is twice as much as we saw in the last group. If you just look at those that had the problem, and again, our alignment goals are met. So this is an important piece. The other thing is, like, when we looked at this data, 42% had an ACR of sorts, whether it was at the ALIF level or at a lateral level. So you can see us really using the anterior column a lot more. So if we ask ourselves, does LIF in 2019, or I would even challenge even in 2021, provide you with lordosis you need in the setting of MIS? Well, for mild and moderate, I say heck yes. In the severe, I think it's still a little bit surgeon dependent, but using aggregate data, a little bit unsure. Using individual data, you may find that you're definitely able to get there. And then back to the other question, every surgeon has a unique ability to accomplish lordosis, and you have to know your own limitations. So as you go out from fellowship into practice, please, please, please pay attention to your own data. So here's this case that I'm going to show you that we kind of been working through throughout this process. She has this mismatch here of about 36 degrees in her lordosis. Her TPA is high and her SVA is high. Her bone quality was good, so we were okay to keep moving. This is her CT scan that we looked at already. So she's got air in the disc spaces. She's got a 3-level fusion in the mid-lumbar spine. So on her, we did the ALIF at the base. We did laterals up top, including an ACR. The goal here was to use, again, the anterior column to achieve coronal and sagittal realignment. Here you can see the sagittal plane we corrected as we intended. Here she is positioned after the anterior surgery, and you can see our alignment goals are met here. So when I see this, now I know all I need to do is lock it in place. I don't need to do anything else. I don't need to osteotomize, I don't need to take facets down. This patient just needs to be locked in. And that's what we achieved here, like I said, with the lordosis restoration and her TPA back to where you want it to be. In the coronal plane, I use a T-square to kind of help me figure out where I need to be. On the right image, you can see we're still off from midline. So in this case, I usually place all the screws, but then I only put one rod in. Here you can see I put the left-sided rod in. I was able to use that to realign her. You can use a little in situ bending to shift things around. We got her lined up. The T-square, I like for it to end up between the pedicles of T1. So you can see we achieved that there. And then post-operatively, always assessing where you're at in the AP and lateral planes. So this is what she ended up looking like. To our comment earlier about pelvic fixation, I would say in this day and age, 2021, in my practice, you're getting iliac screws with this construct. Thankfully, she did not fail, but I use iliac fixation routinely anytime I'm at L2 or higher. So MIS is a good option for mild to moderate deformities. Understand your skill level is really important, especially as you start tackling more severe deformities. ACR can be an incredibly valuable tool in the sagittal plane. The anterior column really is our workhorse for MIS surgery. Posterior fixation is the rebar like in a building, and track your data. Thank you, guys.
Great stuff, Greg. Thank you. Thank you so much on behalf of everybody. Couple of questions. So many questions, little time, but let me just fire them. Personal comment first. I loved your thought of being opportunistic, being thoughtful, and being very conscientious about pre-planning. being opportunistic about air and discs and relying on discs for lumbar discs for interbody fusions to have true fusions is essential. First thought is, as you're showing these beautiful prone x-rays, should we maybe add those to our preoperative assessments? I mean, I'm intrigued by what we have all seen intraoperatively, but we've never standardized, because compared to the standing up EOS films, now having a prone position full length film does open up a whole different venue for preoperative planning. Any thoughts on that?
Yeah, I really like it. Like I said, not everyone has the ability to take a long x-ray like that in the operating room. You can buy the cassettes, and it's just a matter of your x-ray tech processing it. So I actually find it a lot easier to get the long cassettes in the lateral position than I do getting an AP or a PA view of the spine, because of the distance that the x-ray has to have for excursion. So the lateral is usually not a problem. But yeah, I think it's tremendously valuable. And also, I think Larry Lenke has written several papers on, at least I know one, where they looked at patients when they were prone and realized that the invasiveness of the surgery changed, right? They didn't have to do as much as they thought they had to going into it. And I think that's certainly been my experience as well. So I most certainly use it as part of the planning process. But I'll tell you, a prone x-ray in the office is not nearly as good as a prone x-ray in the operating room. Once you put them under anesthesia, you really see that change. And I think it may have been Lehman that wrote that up, where he looked at the pre-op standing, pre-op supine image, and then an intra-op prone, and like even to the intra-op prone, you got a lot more correction. So I think patients really to relax need the anesthesia and need to be positioned.
Super, thanks for these observations. Then the other question is a technical one again. Mark Dekutowski pointed out in reference to Bob Hart's comment earlier, his reduction technique for MIS ROS really starts with putting the rods in cephalic and then goes caudally. Most of us traditional open surgeons start with the pelvis and then work our way up. So what is your answer to that?
I always start in the pelvis. So in MIS surgery, you have to, like, one of the big challenges is getting the fractional curve right. If you don't get the fractional curve right, you screw the rest of it up. And so for me, I always put my rods in distally. I lock the bolt to S1 because now I have a solid foundation, and now I can manipulate the L4 to S1 fractional curve or L3 to S1 fractional curve, depending where the curve's at. But I manipulate that first. I usually use compression first because that will enhance lordosis, use distraction next after that, and then allow the rods to reduce the rest of the way on the way up. To Bob's point, the top screws, like let's say we're doing a T10 to ilium, once that T11 screw has been reduced, the rod at T10 should be safely hubbed inside the screw. You could just put a set screw in. Even in the MIS setting, I'm still really, really belligerent about not using a reduction tower to get that top set screw in, because it tells me it's under too much tension. So I do like the thought, if I'm going to try to affect the pelvic tilt, if I'm going to try to affect the fractional curve, it's far easier, in my opinion, to do that with the ilium fixed first and then build your way up.
So yeah, Mark is answering the chat room. Thank you so much for a great talk, and I second that. I have a final question, and we can just run over a little bit because all of us are delayed with our COVID restrictions. Supplemental rods have become very popular. So the kickstand rods, the spanning rods, bridging rods, etc. How do you see that with this MIS approach? Is this something that we shouldn't have to do if you do a good job, obviously, in the first place? But is there an advantage to having multiple rod fixations? And this is something that is MIS compatible? Thanks for addressing that.
Yeah. So like this bowel classification paper changed how I do MIS surgery, because a lot of type C curves, I don't do MIS anymore. I just open them up. I've had too many patients end up coronally malaligned. And it's more challenging for that third rod in the MIS setting because you just got a limiting working space. And at some point, I will say the invasiveness of MIS surgery is greater than a good open surgery. And I think you have to, I don't know where that sweet spot is yet, but I'll tell you, there are plenty of patients I've operated on MIS that did a lot worse than patients I did just the traditional open T10 to P on. So I'm in, like I'm a little more conservative, I assume, than saying everything is MIS. That's not true in my hands at all. I'm at least 50-50. If I feel like I have a type C curve or a type A curve that I'm turning into a C curve, like that patient gets usually gets an open surgery so that I can do exactly what you're talking about. If I need to use a kickstand to really jack them over to one side, then I think it's just a lot easier done. Now, that being said, I think I have done one or two in the MIS setting, so it's doable. It's just, it gets more incrementally painful the more you have to do like that. These surgeries get longer and more painful. So I caution.
So we'll have to close now, but great talk. I like the grrr part because it represents the frequent frustrations. Nothing is harder than repairing misdone scoliosis fusions. That's, again, my one gripe. I see a lot of MIS surgery done. I don't have a problem with it. But what bothers me is that basically just a couple of segments had hardware thrown in and the curve is actually worse than before. So just what you said, that negative conversion. But being opportunistic and always following the guideline of doing what's best for the patient should not be a cliche, but our guiding light. And you greatly contributed with your very thoughtful and very independent and big picture purview that was not dogmatic. So thank you for that.
Of course. A pleasure being here, guys. Have a wonderful day and week, and thank you for having me.
Servus.
Servus. Bis bald, hoffentlich.
Ja.